Hi there, my highly esteemed and treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession. I am the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare sector workers. We are the virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I would like to urge you to sit back and spare me part of your precious time to share some tips that you may find useful in your line of duty. The first question reads, Madam QKM, a 35-year-old female, is admitted for hypertension. Numerous etiologies have been ruled out by the clinical team at your hospital. They opt to consult pharmacy for any potential drug-induced hypertension. Now, Madam QKM has been taking gabapentin, aspirin, tramadol, tadalafil, and rivaroxaban. So my question to you is, which of the pairs listed below is the most probable cause of the hypertension that Madam QKM is experiencing? Is it rivaroxaban co-administered with tramadol, or is it gabapentin co-administered with tramadol, or is it rivaroxaban co-administered with tadalafil, or is it the gabapentin tadalafil duo? I'll give you 10 seconds to choose the correct answer. My opinion, C is the correct answer. It is rivaroxaban co-administered with tadalafil. Now, phosphodiesterase 5 inhibitors may interact with rivaroxaban, leading to excessive hypotension like this patient is experiencing. Now, while excessive gabapentin and tramadol doses can lead to some degree of hypotension, this isn't the best answer for this particular question. Now, rivaroxaban, which is marketed as Adempas, is one of the most recent additions to the drug therapy of pulmonary arterial hypertension. It causes smooth muscle relaxation by stimulation of soluble guanylyl cyclase. It is contraindicated in pregnancy. It's category X to be specific. So never administer it in pregnant mothers. It cause havoc. Just by the way, let's move to the next question. A 69-year-old white female presents to the cardiac clinic at your hospital for treatment or management of hypertension. For the past 3 days, her home BP readings have been as follows: 157 systolic, 97 diastolic, 161 systolic, 99 diastolic, and 155 systolic, 95 diastolic. Now, this dear lady confirms full compliance with her regimen and denies any complaints. So side effects are not a challenge to her at the moment. She currently takes 40 milligrams of fosinopril once daily, alongside 25 milligrams of hydrochlorothiazide after her breakfast and 10 milligrams of amlodipine once daily, together with 50 milligrams of metoprolol twice a day. Some of our vital signs today include a blood pressure of 159 systolic, 99 diastolic with a heart rate of 63. So you give her some time to calm down and relax and take the measurements once more and the systolic blood pressure rises to 161 while the diastolic blood pressure falls to 97. Clearly her readings, her BP is not well controlled. So my question to you is, how would you classify this dear lady's hypertension basing on the information provided in the text above? Is it isolated systolic hypertension, or is it resistant hypertension? Or could this be a case of hypertensive emergency? Or you think she is experiencing hypertensive urgency? I'll give you 10 seconds to choose the correct answer. In my opinion, she is experiencing resistant hypertension. She has resistant hypertension since she has poor blood pressure control on 3 or more antihypertensive agents. Remember, this lady is taking hydrochlorothiazide, fosinopril, metoprolol, and amlodipine. Those are 4 in number. They're supposed to help her lower her blood pressure, but apparently they are not. And these are from different classes, with one of them being a diuretic, that is hydrochlorothiazide to be specific. Now, she doesn't meet the definition of isolated systolic hypertension, neither does she meet the definitions of hypertensive urgency or emergency. Now, those last two require a systolic blood pressure of 180 or more and a diastolic blood pressure of 110 or more. So that's just a by the way to clarify why I strongly feel this lady has resistant hypertension. Let's move to the next question, please. JGO, a patient with uncontrolled hypertension, is referred to your cardiac clinic for rationalization of therapy management. This gentleman's history, current medication therapy, and vitals are keenly reviewed by your team and is found to be on appropriate therapy but still needs further blood pressure control. The clinical team decides to initiate an antihypertensive with alpha-1 blocking effect in order to enhance vasodilation, which would positively impact the afterload. So my question to you is, which of the drugs listed below falls in this class and exhibits this mechanism of action? Is it hydralazine? Could it be clonidine? Is it terazosin? Or is it propranolol? I'll give you 10 seconds to choose the correct drug from the list of 4. Terazosin it is. C is the correct answer. Now, examples of alpha-1 blockers include doxazosin, prazosin, and terazosin. Then examples of mixed alpha beta blockers include Carvedilol and labetalol. And clonidine, which is alternative B, is an alpha-2 agonist. It's not a blocker. While hydralazine is a direct arterial vasodilator, which acts by increasing the cyclic GMP, causing relaxation of the arteriolar smooth muscles. And that's the mode of action by which it lowers blood pressure. Now, propranolol, on the other hand, is an unselective beta-1, beta-2 blocker. So, in my opinion, C is the correct answer. Let's move to the next question. Reads, which of the drugs listed below would increase the serum levels of statins, that is the HMGO coenzyme reductase inhibitors, and increase the risk of myopathy through a phase 2 mediated drug interaction if co-administered with the statins during the management of dyslipidemia. Is it niacin, gemfibrozil, ezetimibe, or fenofibrate? I'll give you 10 seconds to choose the correct answer. So gemfibrozil it is. Gemfibrozil, which is marketed as Lopid, and not fenofibrate, which is marketed as Trico, is known to inhibit phase 2 enzyme, the UGT to be specific, which is used by all the statins. The remaining drugs have no relevant interactions with statins at all. Now, gemfibrozil's bioavailability or its absorption decreases when it's taken with food. That's just for your information, and it should be taken on an empty stomach. So when you are dispensing to your patients, remind them to take gemfibrozil on an empty stomach. But I would like to caution you that this increases the GI side effects. So some patients may not find this pleasant, and it could have a negative impact in that it would reduce their compliance or adherence to therapy. Fenofibrate causes an elevation in serum creatinine more than gemfibrozil. However, the GFR is introduced by fenofibrate. That's just a by the way. So in my opinion, gemfibrozil it is. Let's move to the next question. A male patient by the name LWP, who is 57 years of age, presents to the cardiac clinic for the evaluation of his stroke risk. He has a past medical history of persistent fibrillation, hypertension, and type 2 diabetes mellitus. Currently, he takes 12.5 milligrams of Carvedilol twice daily, 12.5 milligrams of hydrochlorothiazide, a gram of metformin after breakfast and after dinner, and 10 milligrams of glipizide once daily. So my question to you is, which of the recommendations listed below would be the most appropriate for LWP now? Is it the Charles 2 VASC score is 1 and anticoagulation is needed? Or is it that the Charles 2 VASC score is 1 and aspirin therapy is needed? Or is it that a Charles 2 VASC score is 2 and anticoagulation is needed? Or is it true that the Charles 2 VASC score is 2 and aspirin therapy is needed? I'll give you 10 seconds to choose the correct answer. So in my opinion, C is the correct answer. Now, LWP has a Charles 2 VASC score of 2 based on a history of hypertension and type 2 diabetes mellitus. Now, when the score is 2 or greater, the patient is considered moderate high risk, and such patients should receive anticoagulation. Now, the Charles 2 VASC score is based on several factors, including age. So for patients below 65 years of age should score 0. Those between 65 and 74 score 1. Those who are 75 or older score 2. And when it comes to gender, the female gender scores 1, the male gender scores 0. When it comes to the CHF history, if the patient has a history, that is, if the answer is yes, the patient scores 1. If it is no, the patient scores 0. And if the patient is hypertensive, he scores 1. And if there is a history of stroke or TIA or thromboembolism, then the patient scores 2 for a yes. If there is a vascular disease, a patient scores 1. And if there is diabetes mellitus, the patient scores 0. So that explains how we arrived at a value of 2. Now, patients with CHADS2 VAS score of 1 are considered low moderate risk, just for your information, and they may receive antiplatelet or anticoagulation therapy. Now, the CHADS2 VAS score is the most widely used stratification system for determining stroke risk in patients, especially those with AFib, just for your information. Let's move to the next slide, please. Mr. R.A.O., a 57-year-old male patient, presents to the cardiology clinic for further treatment. He has a past medical history of stage C heart failure. Now, he belongs to the New York Heart Association functional class 3. He is also hypertensive. Currently, he takes ramipril, aspirin, metoprolol succinate, and furosemide. And his labs are normal today. His vitals are stable and unremarkable, according to your clinical team. So my question to you is, which other treatment modality would the clinical team consider adding to RAO's therapy to offer him mortality benefits? Is it doxazosin, spironolactone, clonidine, or the diuretic triamterene? I'll give you 10 seconds to choose the correct answer. In my opinion, spironolactone is the correct answer. Now I'll refer you to the RAILS trial, RALES, which evaluated spironolactone use and was stopped early due to the mortality benefits in patients with the same type of heart failure as the one we've seen in RAO's case. When feasible, clinicians should first utilize treatments with proven mortality benefits and then add on other treatments as necessary, those which may not necessarily add any mortality benefit. Now, spironolactone regulates the RAS system, the RAAS system, and reduces remodeling of the heart from the effects of aldosterone. That's what gives it an upper hand. Now, doxazosin, which is alternative A, is an alpha blocker that may actually worsen outcomes in Mr. RAO's case and other patients with heart failure. According to a trial that was done, the ALLHAT trial, so it should be added to other therapy when needed, not as first line. It should not be the drug of choice. Then the diuretic alternative D, which is triamterene, is a potassium sparing diuretic which has no clear mortality benefit in the heart failure patients. Now, alternative C, which is clonidine, is an alpha 2 agonist with no clear benefit in heart failure. It can help aid in blood pressure control after other therapies have been maximized without achieving BP control. Now, prior to initiating spironolactone for the treatment of stage C or class 3 heart failure, like in this patient's case, the serum potassium levels should be assessed, since such patients should already be on ACE inhibitors anyway, and ACE inhibitors are known to increase serum potassium levels. Now, co-administration of loop diuretics helps fluid volume management and causes loss of potassium in urine. That's just for your information. Let's move to the next question, please. A 55-year-old patient seeks a second opinion from you on whether to initiate statin therapy or not. This patient has a past medical history of gout, occasional lower back pain, stage 1 hypertension, and his history, the 10-year history of atherosclerotic cardiovascular disease risk score is 7.3%. You propose he obtains a coronary artery calcium score to help determine if statin therapy is indicated. So my question to you is, which statement below regarding coronary artery calcium score or scoring is correct? Is it true that if the CAC score falls between 1 and 99 and the age is above 55, then withholding a statin would be favored? Or is it B, if the CAC score is above the 75th percentile, statin therapy is indicated? Or is it CAC measurement can be beneficial to obtain in patients on statin therapy to determine if statin therapy can be discontinued? Or is it true that if a patient has a strong familial or family history of premature ASCVD and a CAC score of 0, then the statin therapy isn't necessary? I'll give you 10 seconds to ponder over which of the 4 statements is correct. In my opinion, B is the correct answer. Now, as per the ACC/AHA lipid guidelines, for patients with a score greater than 100 and or greater than the 75th percentile, statin therapy is recommended. Now, for patients with a CAC score of 1 to 99, statin therapy is favored, especially for those above the age of 55. Now, CAC measurement has limited utility in patients already treated with statins. CAC scoring is best utilized when clinicians are uncertain about whether to initiate a statin or not. So if a CAC score is 0, treatment with statin therapy should be withheld, except if if the patient happens to be a persistent cigarette smoker, or if it happens to be a patient with type 2 diabetes mellitus, or for the case of those with strong family history of premature ASCVD, and apart from that, those with chronic inflammatory conditions such as HIV infection. Now, CAC testing should be considered in intermediate risk or borderline risk adults when the decision about statin use remains uncertain. A CAC score predicts atherosclerotic cardiovascular disease events in a graded fashion and is independent of other risk factors such as age, gender, ethnicity, and so on and so forth. That's just by the way to clarify why B is the correct answer. Let's move to the next question, please. It reads, which indication listed below isn't an FDA approved indication for Rivaroxaban? Is it A, reduce the risk of stroke and systemic embolism in patients with prosthetic heart valves, or is it reduce the risk of stroke and systemic embolism in patients with non-valvular atrial fibrillation, or is it prophylaxis of DVT, or is it treatment of DVT and PE, and for the reduction in the risk of recurrence of DVT and PE? I'll give you 10 seconds to choose the correct statement. In my opinion, A is the correct answer. Rivaroxaban is indicated to reduce the risk of stroke and systemic embolism in patients with non-valvular atrial fibrillation, the treatment of DVT and PE, and for the reduction in the risk of recurrence of DVT and PE. It can also be used for the prophylaxis of DVT. Its safety, however, hasn't been studied in patients with prosthetic heart valves at all. If you read the literature, it doesn't figure. Therefore, in my opinion, its use isn't recommended in this category of patients. So that makes A the correct answer. Let's move to the next slide, please. So it reads, JKT, a 66-year-old female, is diagnosed with acute pulmonary embolism. She is receiving enoxaparin at a dose of 1 mg per kilo sub-Q twice daily and has been initiated on warfarin 5 mg once daily orally. So my question to you is, why is this duplicate anticoagulation therapy justified in the case of JKT? Is it true that it isn't appropriate and enoxaparin should be discontinued? Or is it true that enoxaparin inhibits proteins C and S, resulting in a hypercoagulable state? Or is it true that warfarin doesn't provide acute anticoagulation therapy? Or is it D, warfarin requires antithrombin to inhibit or for the inhibition of therapeutic effect? I'll give you 10 seconds to choose the correct answer. C is the correct answer. Warfarin doesn't provide acute anticoagulation therapy. Now remember, in patients with acute PE, they should receive therapeutic anticoagulation with low molecular weight heparins, or with fondaparinux, or with unfractionated heparin, with early, where early means even the same day if feasible and possible, warfarin initiation. You have to do some bit of bridging. Now, as a result of the acute ongoing emboli, immediate anticoagulation is necessary in such a patient. However, warfarin typically requires like 3 to 5 days of therapy before therapeutic INR is ever achieved. Warfarin initially prevents the antithrombotic effects of protein C, S, and Z, and that can be risky because it creates a procoagulant state prior to preventing the activation of factors 2, 7, 9, and 10. So that small window can be very dangerous if you don't co-administer the 2. Could cause coagulation instead. Now, for acute VTE, initiation of warfarin therapy requires bridge therapy, which I mentioned a short while ago, and the therapeutic anticoagulation using LMW, fondaparinux, and unfractionated heparin should occur concurrently to avoid coagulation. Now, just like to emphasize that patients receiving apixaban, dabigatran, edoxaban, or rivaroxaban do not require bridge therapy. That's the advantage they have over warfarin. And the reason is they are considered to be therapeutically active within 2 hours of administration, whereas warfarin only takes effect after the body has gotten rid of the factors 2, 7, 9, and 10 that are in circulation. They don't affect whatever is already circulating in the bloodstream. Now, patients diagnosed with PE typically require anticoagulation therapy for like 90 days, 3 months to be specific. And patients taking this medication beyond 3 months should be reassessed for indication for prolonged anticoagulant therapy. They should also be assessed for the risk of bleeding so that we weigh benefits and risks and decide whether to prolong therapy or not. Now, when counseling them, the patients on warfarin therapy, it is important to educate them that they may eat foods containing vitamin K. However, the portions, the weekly portions, need to be kept constant. Don't, for God's sake, bar them from taking any foods with vitamin K. That would be wrong. That's just a by the way. So let's move to the next slide, please. So which of the lipid lowering therapies listed below can cause undesired increases in TG while also lowering LDL cholesterol? Is it statins, which are also called the HMG CoA reductase inhibitors, or is it bile acid binding resins like cholestyramine, or is it the fibrates, or is it the selective cholesterol absorption inhibitors? I'll give you 10 seconds to choose the correct answer. So in my opinion, it is the bile acid binding resins. Now these resins, which include cholestyramine and choleselavim, those are the commonly used ones in therapy, can cause an increase in TG while reducing mainly LDL cholesterol. This is clinically relevant to patients whose baseline TGs are elevated, that is above 200 milligrams per deciliter to be specific. And examples of such scenarios may be, for example, uncontrolled type 2 diabetes mellitus patients, or HIV infected patients who are taking PI based regimens as their heart to be specific. Now they also cause drug interactions, and there might be need to separate them from other medications being taken concurrently so that they are not bound, so that they don't bind those other medications. Now selective cholesterol absorption inhibitors and statins decrease LDL cholesterol, and they can also decrease TG, so they would not be the best options in this particular question. And fibrates primarily reduce TG, and they can raise HDL slightly. So that explains why B is the correct answer. Let's move to the next question, please. Which of the antihypertensives listed below is associated with hemolytic anemia? Is it Carvedilol? Is it methyl dopa, indapamide, or whitetensin? I'll give you 10 seconds to choose the correct answer. So methyl dopa aldomet it is. Now methyl dopa is the only listed drug which results in a positive Coombs test, which is a test that tests for the presence of hemolysis. It does this by looking for antibodies that may be bound to the red blood cells, and that such antibodies may cause premature destruction of red blood cells. There are two types of Coombs tests, the direct and the indirect one. Now the direct Coombs test is used to detect antibodies that are already bound to the surface of the erythrocytes, the red blood cells. Now the indirect test looks for antibodies circulating in the blood stream. So that's just by the way. The other three, A, C, and D, do not cause hemolytic anemia at all. Let's move to the next slide. Reads, which of the conditions listed below is a contraindication for the therapeutic use of Prasugrel? Is it age above 75 years? Or is it a history of transient ischemic attack? Or is it renal impairment? Or is it a state of being underweight, weight below 60 kilos? I'll give you 10 seconds to choose the correct answer. So B, it is transient ischemic attack. Now, Prasugrel, which is marketed as Efficient, is a thienopyridine antiplatelet medication which irreversibly blocks the P2Y12 component of the ADP receptors, just like clopidogrel, ticagrelor, and so on and so forth. Cerebrovascular accident and or transient ischemic attack are absolute contraindications to Prasugrel use if you read the literature inserts. Now, an age of above 75 years or a weight below 60 are relative contraindications if you read those inserts carefully. In my opinion, there are no dose adjustments necessary for renal impairment with Prasugrel. These recommendations can be found in inserts, so I would recommend you read them, and they are based on what we call the Triton TIMI 38 trial, TRITON-TIMI 38 trial. That's just a by the way to clarify why answer B is correct. Let's move to the next slide, please. A 73-year-old Kenyan female presents to the cardiac clinic with a past medical history of coronary artery disease, status post-MI, which she underwent 6 months ago. She is hypertensive and suffers from dyslipidemia. She informs you she experiences 4 to 5 chest pain episodes every week, usually during exercise or when she's stressed. Now, these episodes resolve with the rest, though they may take a duration of 10 to 15 minutes occasionally. So my question to you is, which of the medications listed below would be the most ideal for quick relief of angina pain in this patient's case? Would it be nifedipine, 100 milligrams PRN? Would it be sublingual nitroglycerin administered at a dose of 0.4 milligrams when necessary? Or would you administer 0.1 milligrams of clonidine when necessary? Or would you advise the patient to chew 325 milligrams of aspirin when necessary? I'll give you 10 seconds to choose the correct answer. In my opinion, sublingual nitroglycerin administered at 0.4 milligrams when necessary would be the correct answer. For quick angina relief, short-acting nitrates such as sublingual nitroglycerin are the medications of choice. Now, the short-acting dihydropyridine calcium channel blockers like nifedipine, which is alternative A, aren't recommended for angina relief as they can activate the sympathetic nervous system, generally in response to a quick drop in blood pressure, and that can lead to tachycardia and a potential worsening of the angina episodes. So don't use nifedipine in such cases. Now, alternative C, clonidine, while frequently used to manage elevation of blood pressure in urgent conditions, isn't used for routine angina management at all. It doesn't appear anywhere in literature or in guidelines. Alternative D, aspirin 325 milligrams PRN should be used if the patient is experiencing an MI, not a case of angina, and that is majorly to minimize the extent of the thrombus formation because it's an antiplatelet agent. So we'll capitalize on its antiplatelet properties to control the MI. It has no role in the management of angina at all. So all those many words explain why alternative B is the correct one. Let's move to the next slide, please. In which of the conditions listed below would you use aspirin in pregnancy? Would it be in a case of oncoedema, preeclampsia, migraine headaches, or what we call the Braxton-Hicks contractions during pregnancy? I'll give you 10 seconds to choose the correct answer. So preeclampsia it is. Now preeclampsia is the only listed condition in which aspirin may be used if the patient is a high risk one around 12 weeks of gestation. Now aspirin can make oncoedema worse due to its effect on renal perfusion that could activate the RAS and cause worsening of fluid retention, which can lead to edema. So don't use it in such cases. Now the Braxton-Hicks contractions are non-life-threatening sporadic uterine contractions that usually occur early in the first trimester. They do not require treatment. Treatment is not recommended at all for them. While aspirin can be used to treat migraine headaches, it is usually not first line, especially for the pregnant women experiencing migraine headaches. So my highly esteemed viewers and listeners, that brings us to the end of part 34 of our pharmacotherapy MCQ series. If this video helped you in any way, I would like to remind you to give it a thumbs up and to like it and to share it broadly with your peers and colleagues and workmates. And if you haven't yet done so, I would encourage you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come, and I would like to thank you sincerely for viewing this video and listening to me. I'm very grateful for the sacrifice and for the support that you continually offer me, and I look forward to interacting with you in part 35 of our pharmacotherapy MCQ series. So thank you very much.